Okay, so hello everyone. Today we have, sorry, everything okay? Yeah. Dr. Solomon Aremu presenting on myocardial fibrosis with us today. And it will be an interactive session, so there will be some polls to which you can either message your answers in the chat, or hopefully we can make it interactive through Zoom as well, so you can select your answer there. And yeah, I think if you want to start, yes, the floor is yours.
Awesome. Thank you so much. Let me see if I can quickly share my screen. Sure. Great. Oh, great. Good evening, everyone, and good morning or afternoon from wherever you might be joining us from. Can you hear me very well? Oh,
yes,
great.
Yes,
yes. So today I'll be talking about myocardial fibrosis, and I just want to put a bit of disclaimer that I'm not a technician and I'm not a radiographer. So I'll give background to myocardial fibrosis and tell you what we do in our practice. Okay, so this is how the lecture outline will be. We give a brief introduction of myocardial fibrosis and talk about tissue characterization, zooming in into the emergence of cardiovascular magnetic resonance and how how I can say it supersedes or is superior to the other imaging modality. So imaging modalities rather. And then we look at some of the parametric mapping that came up after gadolinium, after introduction of gadolinium CMR. And then we do some review questions just to test our understanding of the whole lecture. Okay, so just to start with, we can say that there are some fibrotic remodeling that happens in the extracellular matrix, and this is a necessary physiological process. Tissue healing, wound healing is a necessary physiological process, and during this physiological process, there is a kind of deposition of collagen, not too much, but when it becomes excessive, then that is where the problem is. So now that we're talking about myocardial fibrosis, then we're talking about the deposition of collagen in the myocardium, which is our heart. So this a prolonged increase in this myocardial fibrotic activity is the one that allowed adverse outcomes, which is related to the dysfunction we see in the systolic and diastolic arrhythmogenesis. Okay, so myocardial fibrosis, which is defined by a significant increase in deposition of collagen volume fraction of myocardial tissue, is always present at the end stage heart failure. Not only heart failure, some other diseases such as maybe the valvular heart disease, the hypertensive heart disease, and even in aging, there is a kind of deposition of fibrosis that happens, but it's just that that is a normal process. Aging, in aging, all your organs begins to shrink a bit. So even the myocardium, all those organs, they begin to shrink. It's just a natural process, you see, because of aging. So it happens in the heart too. But when it is in a disease state, such as heart failure, then you see the deposition of collagen, which is in the increased state. Okay, so the distribution of this myocardial fibrosis varies according to the pathology that we are looking at. And this is what accounts for the discrepancies or the differences that we see among different pathological reports in which only qualitative as opposed to quantitative measurements were made. Two things we have mentioned here now, qualitative. So looking at qualitative now is what you can see. So that one is like subjected or subjective to who is looking at it, who is seeing it. And then quantitative is what you can measure. You can see the quantity of what has happened. Okay, I am showing this image just to explain to us that myocardial fibrosis is a complex process that involves each cellular component of the myocardial tissue. And the myocardial fibroblast has a central position in this process by increasing the production of collagen and other extracellular matrix components under the influence of various factors which are listed, such as renin-angiotensin system, myocyte apoptosis, which is programmed cell death, pro-inflammatory cytokines, and reactive oxygen species. And just a quick run on the image, we see that cardiomyocyte on top of this. I think I was using laser the other time. Okay, let me just quickly get my laser and point. Okay, so if possible, I want to shift this downward. Oh, great, awesome. Okay, so so this is your cardiomyocyte, which constitutes about 75% of the myocardial structure space. You will appreciate the reason why we have to look at it at the cellular basis by the time we get to, the emergence of cardiovascular magnetic resonance now. So this cardiomyocyte, which is 75% of the myocardial structural space, we have the cardiac interstitium, which constitute about 25% of the myocardial structural space. And this cardiac interstitium is composed of the blood vessels, which have the capillary and the arterioles, endothelial cells, vascular smooth muscle cells, macrophage, and mast cells. And we also see the myofibroblast there. So there is an interplay between all this. Collagen is there, that's our player there. And when there is an interplay, when in times of tissue injury, now there is a loss of cardiomyocyte, which we see in the reactive interstitial fibrosis, and in disease states such as hypertension, valvular disorders, diabetes, some genetic diseases, and aging, just like I mentioned the other time. So when cardiomyocyte is lost, but it's not significantly lost, then we see a kind of reaction or reactive interstitial fibrosis. And then we also see the infiltrative interstitial fibrosis, and these are to do with a kind of deposition of some lipids, sphingolipids. You see in the myocardium, you see amyloidosis, and we have Fabry disease, which is a genetic disorder. Those are the interstitial fibrosis that we have. And then we see the other one, which is the replacement or scarring fibrosis. And this is just as the name implies, replacement or scarring. So there is deposition, accumulation of the or deposition of collagen, and upon the dead tissue. So the dead tissues are being replaced by the collagen, and then when this happens, that is when we have the scarring fibrosis or the or replacement fibrosis, and we can see this in inflammatory diseases. We see it in acute or chronic ischemia, myocardial infarction, renal insufficiency, in the chronic stage, myocarditis. I know we are all familiar with all these names, sarcoidosis, genetic, and then toxic myocardium, as the case may be. Okay, now there is cardiovascular magnetic resonance imaging. And if I just zoom in into contrast enhanced MRI now, say it's a non-invasive, clinically useful technique, which is accurate for quantification and localization of the fibrosis or the myocardial fibrotic burden that we have been mentioning before in that image. Okay, and this it does by probing the retention of gadolinium contrast agent by myocardial tissue. So what happened is that, just a brief principle of how gadolinium works. So the extracellular matrix of the heart, there is this interstitial space. Sorry, I should have put some images so that you grasp what I'm talking about. So there are some spaces. So when you inject gadolinium into the myocardium, it is expected to move into the myocardium and then move out. So we call it kinetics of myocardium, washing and washout effect or principle of gadolinium. So it's not supposed to stay in the extracellular matrix. So it stays in the extracellular matrix, taking the space of the interstitium and then expanding the extracellular matrix. And that is when you look at, oh, the volume of the myocardium that has retained this gadolinium. That is where you see enhancement on cardiovascular magnetic resonance. That is where you see the volume that is being enhanced, and then taking the volume into account, you can calculate the percentage in cardiovascular magnetic resonance. I hope I'm still doing well. Okay, I got a call just now. I thought my facilitator is the one that is calling me. All right. So am I still doing well there?
Yes, all good.
Awesome. Thank you so much. Just checking. Okay, so that is how it is. So I have given a brief of what happens in myocardial fibrosis. And I don't know if you can just roll the first audience poll so that I will know how many people are following me actually.
Sorry, can you repeat if I can load the audience?
I said, can you load the first question? Is it possible for you to load the first question?
Yes, so actually, if you have the questions on the PowerPoint, maybe it's easiest if they write their response on the chat, because I couldn't actually find the questions in the email. I didn't see the attachment.
Okay, I see what you're saying. Okay. I'm on presenter mode here, so I can't just scroll down to where I'm, but we can continue. It's okay. We can do everything at the end of the lecture. It's just that I wanted the question to be going as long as we go so that people can be following based on it, but it's okay. It's fine. All right. So that is what it does. I believe we understand the principle of gadolinium now and how it is being retained in the myocardium, in the myocardial tissue. Okay, so let's gadolinium now, enhancement imaging. I have mentioned the word enhancement and I've explained how it enhances or why, or let me say, it gives a bright signal. Let me say, it gives a bright signal. That is the term enhancement. That is what it means. So now, this is done within 10 to 20 minutes of image acquisition. After injecting the gadolinium or the contrast agent, then within 10 to 20 minutes, then you begin to see the signal. So the early signal you see has some clinical implications, and the late signals you see has some clinical implication. And this is where the late gadolinium enhancement comes in. It is late because we look at how much of the myocardium retains this gadolinium in the myocardium. So late gadolinium enhancement imaging can be used to identify the presence of scar or fibrosis, the pattern of fibrosis, and the size of replacement of focal fibrosis. And these have proven some prognostic capacity. Now, this presence or the extent or the pattern of fibrosis that we're talking about, they have been shown to independently have prognostic capacity over the risk factors and other imaging modalities in multiple diseases associated with myocardial disease. Okay, I put here, I said as opposed to ST. ST is speckled tracking echocardiography. So LGE, late gadolinium enhancement, allows a more direct in vivo tissue characterization, highlighting the areas with regional extracellular expansion, such as replacement, fibrosis, and scar, just like I mentioned the other time. And what it does is that it accumulates in the expanded extracellular space, and due to their short T1 realization time. What is T1 realization time? So when you put your patient in the scanner, you put your patient in the scanner, remember that the protons we have in the fluid of our body, then they are already in Brownian motion. So when you put your patient in the scanner, the protons will align with the magnetic field of cardiovascular magnetic MRI. So when it aligns like that, you introduce your, what is it called? You introduce your radio frequency. Once you introduce that radio frequency, it permits me to use the word, it chases the protons. It's, how will I put it? It makes them to dance around, if there's a word like that. I don't know if you are following me. I'm trying to make it a bit interesting so that you can get what I'm talking about. So it makes them to dance around. You acquire your image like that. Now it dances around, you excite it. That's the word. You excite the protons. Once you excite it, there is a time that it takes to travel and to come back to the point of excitement. So that is the T1 realization time that we're talking about. The time that it takes the spin, the protons to spin to reach equilibrium and to come back is the T1 realization time. And this appears as a bright signal in inversion recovery gradient echo sequences. And this is what outlines diseased area from the normal myocardium. So just like I said the other time, LG module is acquired 10 to 20 minutes after the contrast agent has been injected. And this it does by leveraging the different washout properties of normal and pathological myocardium. Okay. So over the last 20 years, the number of studies published on LG has increased. And this highlights or let me say it highlights the techniques, diagnostic and prognostic power. So if you look back like 20 years ago that CMR came into play, you realize that it initially, Kim et al. Was one of the first people that were demonstrating the relationship, or let me say they were using this late gadolinium enhancement. And one of his research that he did was that he demonstrated the relationship between the degree of enhancement, the degree of LGE transmorality and functional recovery after coronary revascularization. And this allows myocardial viability assessment by CMR in order to stratify risk in patients or risk stratify patients and guide their coronary revascularization. So they work on this, and what they actually did was that they worked on dogs, and they took 30 dogs, they euthanized them. I mean, they put them to sleep after 1 day, at 1 day, at 3 days, and at 8 days. So they subjected them to MRI and necrosis. So yeah, I don't just want to bore you with all these things they did, but the sequence they used was still 3D gradient echo images. That is what they used to acquire their images. Their slice thickness was 2 millimeters. And what they reported was the wall thickening that was shown. He had his Doppler flow, which is measuring the velocity, the hemodynamics in the heart, the sea wall thickening, and then this is when they use MRI to see the to check the infarct that is going on in the heart of the dog, of the dogs that they check. This is just dog one. But what you will appreciate most here is the excuse me, is the infarcted area of the myocardium here. I don't know if my laser is still showing. Let me pick it again. Okay, it's the infarcted area of the myocardium. Awesome. So another study shows that the presence of LG and its quantification predicted outcomes, adverse outcomes of mortality in coronary artery disease. And this is a study by Sebastian Kelly et al., where they look at the prognostic value of myocardial infarct size and contractile reserve using CMR. And what they did was that, they aimed to assess the predictive value of myocardial infarct size using LG imaging in medically treated patients and chronic myocardial infarction relative to contractile reserve on low-dose dopamine MRI for long-term event-free survival. And what they did is that they took they recruited about 177 patients with known CAD and scar tissue on MRI. And they look at their left ventricular functional parameters at rest and during low dose dopamine MRI. And then they also assess the wall motion. So of importance here is that they concluded that the myocardial infarct size is a stronger predictor of clinical outcome than contractile reserve in medically treated patients. So what we're trying to establish here is that LGE, is that late gadolinium enhancement has been widely used, and the prognosis is actually right, like it predicted adverse outcomes. Okay, so this is just after the follow-up showing the prediction. Okay, another study here is showing that the different LGE distribution patterns occur in the early stage of various non-ischemic pathological processes, and this guides the cardiomyopathy phenotyping and diagnosis. And this is a study by Anderson and Merchant, where they show like two cases. Let me just quickly talk about the two cases. So the first case is a 41-year-old man with asymmetric septal hypertrophic cardiomyopathy. And if you look at the first image here, you see a high velocity jet that can be detected, or that is detected as an area of high intensity, high signal intensity within the left ventricular outflow. You see the bright signal here, the LVOT, on the 4-chamber view. And you can see a spin defacing of the LVOT projection. So the second, and then the short image is a short axis stack of oblique steady state free precession image, which shows an enlarged septum. The septum here, so this is the left ventricle and this is the right ventricle. You can see the spectrum here. I know you're following my laser here. Okay, arising from the left anterior descending artery. And this is a finding that is commonly seen in cases of hypertrophic cardiomyopathy. And then okay, let me see if I can pull this up a bit. Okay, so the last image here, which is not showing, is showing a delayed enhancement in the anterior and posterior right ventricular insertion point. You see where they meet here. You can see the enhancement here. If you follow my laser, the right ventricular insertion points on the short axis oblique delayed enhancement image. And the second image is a 36-year-old man with asymmetric septal hypertrophic cardiomyopathy and systolic anterior motion of the mitral valve. And what is being shown here is, looking at it from the first image to the fourth image, you will see the displacement of the anterior mitral valve leaflet into the left ventricular outflow tract. This place, and then this is accompanied by high velocity jet. High velocity spin defacing jet into the left, into the LVOT. So what we're trying to say here is that the distribution pattern, the LG distribution pattern, it occurs at different stages of non-ischemic pathological processes, and it helps in phenotyping cardiomyopathy, in diagnosing and phenotyping cardiomyopathy. And then another study by Ravi et al. Tells us about dilated cardiomyopathy, about the pattern of enhancement that we see in dilated cardiomyopathy. And this is a frequent or donor-specific sign. It is called midwall stripe. I will show you just now. An intramural region of fibrosis, usually in the basal and or mid-septum. So on the panel, on the two panels above, you will see that there is no arrow. There is nothing showing there. That is the normal myocardium. This is the long axis view and the short axis view. And if you look at the long axis view on the panel, on the third panel here, you will see a stripe, the midwall stripe that we're talking about, shown by this. It is at the midwall, and this is by the posterior inferior, posterior inferior side of the myocardium. That is on the long axis, and on the short axis, you can see what it looks like. It's a wide stripe, a thin stripe, which is phenotypic of dilated cardiomyopathy. And this has been shown to correlate well with histology. So with the histology, you see the histological and autopsy sample correlating with what is seen. See the fibrosis, the lesion that we see on histological sample, and then look at the autopsy sample. You can see and appreciate the wide stripe that is shown here, and then the midwall there, even from the insertion point on the top and below here. All right. So another one that I want to show is the feature of myocarditis. Don't forget that we are talking about myocardial fibrosis, and we are looking at how late gadolinium imaging can help us to diagnose the different diseases of myocardium. And then where we are now is the point where we look at the pattern and features of enhancement that we see in these different diseases. I have explained what myocardial fibrosis is. I have given some information about the types of myocardial fibrosis that we have. I believe you are following very well. So we have some few questions, just like 3 or 4 at the end of the lecture this evening. And then here we are talking about myocarditis, the features we see there. It is subepicardia or transmural LGE. These are some images. How will I put it? Short axis images, long axis images, and then we have another palette here. But let me just give you a brief overview of it. So the palette up here, the PVB19 is parvovirus. So remember that myocarditis is an inflammatory disease of the myocardium. So the myocardium here is of a patient that was infected with parvovirus, The second palette is herpes virus, and the top palette is someone who was infected with parvovirus and herpesvirus. And then the last one is when you see the last palette here on the left is where you see it healing here. So these are the initial stacks that were collected on CMR before, and the arrows are showing the subepicardial and the transmural pattern of enhancement that is seen in this. We can see it on the inferior part, the posterior inferior part of the myocardium. Same here, and then we appreciate it here that it is from the base to the almost to the apex. It is almost transmural on the lung as it's here. Look at the stripe that I was talking about the other time. So this, we cannot call it linear midwall. It is linear in shape, but if you look at it across the myocardium, you can see that it's almost transmural. Same goes with the one on this palette here. And then look at the insertion points. Look at the insertion points of the PVB and the HHV myocardium here from top to bottom. We can see it, and it cuts across the palette here. On the long axis view, you can appreciate the enhancements that you can see. And you can see almost all of them have finished healing here. That is why it was not indicated with any arrow. And then if you look at the palette that is here, this is the these are the images that were collected after or later, and it is also showing the patterns of enhancement here. Same image. I think it was a follow-up study. It was a follow-up study, but they saw a persistent inflammation or persistent, continuous inflammation in the myocardium. So it's like healed, but not completely there. So we can still see the pattern of enhancement in this myocardium. So because of our time, I don't know if I'm doing well with time. Oh, okay, so I've spent like 26 minutes. Okay, let me go on. And then I mentioned Fabry disease as one of the diseases of the myocardium the other time, and that is the infiltrative interstitial fibrosis. And looking at it, we see the characteristic mid-wall enhancement, also epicardial enhancement, which is in the basal inferolateral wall of the heart. Okay, you can see them here. See, so this is the base. So is the point. I mean, this is the base of the left ventricle, and this is what we are looking at on the short axis stack here. So you see the base on the long axis stack, and then you see the equivalent on the short axis stack. Same goes here on the second palette, and same goes here on the top palette. You can see the enhancement. So the myocardium is completely nulled, and the only white area is the enhanced that we are talking about. And same goes with this. So that is a characteristic feature that we see in Anderson-Fabry disease. Okay, so there is also another one that I'm showing here is by Macera et al. And this is a case of amyloid deposit, and we're saying that it usually causes a diffuse subendocardial or transmural LV enhancement. That is one. And then this we also have frequent RV and biatrial involvement with early darkening of blood pool due to abnormal gadolinium kinetics. Okay, so this is the deposit of the sphingolipids, the one that I was talking about the other time. I mean, the proteins of the body, it usually deposits into different parts of the body. So when you are assessing this kind of case, then you also look at the extracardiac abnormalities. You look out for extracardiac abnormalities, and just of interest, you can see in this particular view, you see the four-chamber view, you see a pronounced pleural effusion that is here, and then you can see the pericardial effusion that we found in this is enhanced. So that is the work of LG amyloid deposit. It gives a diffuse subendocardial or transmural LV enhancement, which comes with frequent RV and biatrial involvement. Okay. All right. So that is LGE. And then looking at the era of myocardial fibrosis, we see that there is an era which was where they were using myocardial fibrosis, where they take a bit of tissue, biopsy tissue in the 1960s. They use that, but that is invasive because you have to put your patient to sleep, cut their heart and take a bit of biopsy to perform that. Very invasive. Echocardiography came into play in the 1980s because of some of the disadvantages that we'll talk about just now. CMR also came into play in the 2000s. Speckle tracking echocardiography came into play in 2008, and T1 mapping, which we will go into very soon now, came into play around 2010. Endomyocardial biopsy had some advantages and disadvantages. I have listed them here. So endomyocardial biopsy, it is specific in diagnosis. That's high sensitivity and specificity, but it is invasive and it is also prone or subjected to sampling error. Echocardiography, high availability. In fact, some of them are portable. They are very durable. Non-invasive stuff, even the reproducibility and the repeatability is very nice. Low cost, but it has low sensitivity and low specificity. For the LG image, spatial resolution fine, high specificity, very, very good. But it is expensive and it is also tracking echocardiography. This is an advanced, an advanced form of echocardiography that is being made, available, repeatable, non-invasive, angle independence, specific beat patterns, acoustic window, that is the ambiguity when you are using echocardiography. Then the clinicians will recommend CMR because CMR comes with very good acoustic window, It can quantify myocardial fibrosis very well, and it has a very good prognostic role. It is also highly specific, just like we have been showing in some cases that I have explained before. However, CMR came with low availability, high cost, and then for the sequences that we're going into just now, the T1 mapping, it lacks a bit of standardization. So research is still increasing along that side now. People are really working on it. I will round up this talk with a work that we do that we did in our lab. Okay, so parametric mapping now. T1 and LG mapping. T1 and LG mapping offer comprehensive diagnostic and prognostic capacities for the assessment of myocardial fibrosis. Although T1 can be used to differentiate disease processes or between disease processes, its prognostic capacity has been less tested, compared to LGE. And then how does T1 mapping work? Just like I was trying to explain the other time. So T1 mapping measures the longitudinal or spin lattice realization time, which is determined by how rapidly protons re-equilibrate their spins after being excited by radio frequency. And there are sequences, or there are methods that were being in play in 1970. There is a sequence or method that is called look and local proposed. Yeah, so this methods measure T1 realization time by acquiring data successively after magnetization inversion. And as a result of this, there have been a kind of, they refine these methods and just to like shorten the acquisition time. I believe that is still ongoing now. I think in 2017, there are some people. Dr. Kenashi. Yes, Dr. Katie Menacho. Yeah, I know she will talk about the ultra-fast project. So they're trying to reduce the number of sequences, reduce the time, because that is one big player in CMR, time. So the length of time at which you keep your patient. Yeah, that is one disadvantage of CMR, but I believe work is ongoing now in order to reduce or shorten the sequences. So look and local was modified, and that is when we have modified look local inversion recovery, which is MOLI pulse sequence. And this allows measurement of T1 times in a single breath hold over 17 successive heartbeats. And this has become most popular T1 mapping method. This is what we use in our lab. Yes, we have done some research on the other ones, shortening the modified loop local inversion method, but we still see that MOLI is good and it can answer most questions that you are asking. So the main difference between the conventional loop local and MOLI is that in the later, in MOLI now, the images are acquired at the same cardiac phase, allowing mapping. You can map them pixel by pixel upon one another. So variations of MOLI have been proposed, allowing shortened breath hold and reduced sensitivity to heart rate, such as the 533 scheme, which is shortened, and the shortened, we call it Shimoli scheme, uses sequential inversion recovery measurements with a single breath hold of only 9 successive heartbeats and a conditional fitting algorithm to account for the short recovery period method between inversion pulses. These are technical terms. MOLI, Shimoli. It's very good to know their principle. And some other pulse sequences that are being used in some other clinical practice, SASHA, single saturation recovery, single shot acquisition, and saturation pulse prepared, heart rate independent inversion recovery, SAPHIRE. Okay, sorry, I'm trying to rush through it now because of time, because I still have to show some work that we have done in our lab. Okay, so after T1 mapping, what is it? What do we have again? So we see the newer sequences, which I imagine to better characterize and quantify diffuse interstitial myocardial fibrosis. Okay, let me just state this emphatically now. So LG is very good. LG is good, established, good prognosis, good diagnostic features. It can show you myocardial infarction. In fact, anywhere in the myocardium, good for focal fibrosis. But you see, there are some diseases that come with diffuse myocardial fibrosis. Yes, LG can show them, but it is so scattered. You can see what we saw in the pattern we saw in myocarditis, very diffuse. Almost like you can just see those dots there. But if you want to quantify them, that is where or when you use T1 mapping. So T1 mapping gives a numerical value in milliseconds for T1 realization time of the myocardium in a pixel-wise fashion and standardized scale. So T1 mapping allows for the accurate quantitation of diffuse and infiltrative interstitial fibrosis and has tremendous prognostic potential in a wide variety of ischemic and non-ischemic diseases. Ischemic and non-ischemic diseases are the ones that are due to hypoxia, the ones that are not due to hypoxia. That's what we're just trying to talk about there. Now, These techniques provide better characterization of tissue composition, both on the global and regional level, allowing the detection and quantification of histopathological changes such as the fibrosis, which is impossible to see with LGE. So when you combine information from native and post-contrast T1 maps, the fraction of interstitial space can be measured as ECV. That is the extracellular volume fraction. And then we say native T1. Now that's the time that is coming. Native T1 are the maps that you, or the images that you acquire before your administration of contrast. That is pre-contrast T1 maps. Pre-contrast T1 maps. And then post-contrast T1 maps are the ones you acquire when or after you have given your contrast, after you have administered your contrast. Okay, so ECV is a marker of myocardial tissue remodeling, and this provides a physiologically intuitive unit of measurement. It is different compared to T1 mapping. Let me just say this, it is a derivative of T1 value, T1 mapping, T1 relaxation times, and it makes use of hematocrit. So here I have also put the method of calculation. If you want to calculate ECV, this is it. It is 1 minus your hematocrit value into bracket or multiply by your T1 post-contrast minus, okay, your 1 over T1, the ratio of your post-contrast T1 in the myocardium minus the ratio of your pre-contrast in your myocardium divided by what you see in the blood and what you see in the myocardium. So that is your ECV. It is a derivative of T1 mapping. And most times when you see in diseases, when you see high T1 times, you see that it is proportionate to the ECV values that you find, okay? So it allows for accurate measurement of diffuse and infiltrative interstitial fibrosis. Okay, so this palette is just showing the T1, what I was talking about the other time. After exciting the protons of the body, you see that it takes a bit of time to reach 63% recovery after T1, approximately 63% of it. So to equilibrate, that is what we are talking about. That is the time that we are looking at, the inversion time of T1 image relaxation measured in milliseconds. And we see the different T1 mapping here, T1 on the y-axis and ECV on the horizontal axis here. Yeah, we see it ranges from acute myocardial infarction, very high in MI, amyloidosis, the two types of it, tyrosine and the alpha amyloidosis here, chronic MI, and then it begins to come down from acute myocarditis, systemic sclerosis here, the cardiomyopathy, rheumatic arthritis, normal when it is a big green here, and then you see the Fabry getting lower there, and then lipomatous metaplasia here. So going to this place, so that's why I'm sharing this image, okay? So just some few cases of where we found or where there is a show of increased value of native T1. They have shown good correlation with histologic evidence of interstitial myocardial fibrosis. So on this palette, you see the normal control from the left, and you see moderate aortic stenosis, and you will appreciate the fact that there is a kind of severe aortic stenosis here, and this is being shown on LGE, and it is shown on, it really shows high T1 values in this place, high T1 values in this place, T1 values rather in the middle oh, T1 value rather, yeah. And then this is the correlation. Sorry about that. So this is a correlation that I'm talking about. ECV on the x-axis, and we can see significant strong correlation between the T1 and the ECV value. Okay, however, when you apply T1 mapping in clinical practices, it is still limited due to lack of standardization of the acquisitions, just like I mentioned the other time. And then, yeah, the research is increasing every day. Many efforts are being made to achieve better standardization, with two consensus statements published in 2015 and 2017, and commercial sequences getting available. So people are still building repositories, and research is looking into building special sequences where we can actually say that, are we still going to be using gadolinium? Are we still going to be using LGE? Or we're going to move to, say, T1 mapping and ECU? Okay, so I don't know if I'm still doing well with time. Yeah, my time is far spent here. So I think I will just, okay, ECV prognostic significance. There is a quantification now. Has been demonstrated in different disease subsets such as amyloidosis. I've shown that the other time, so I will just skip this if you don't mind. And then just showing some few images of microscopic and macroscopic fibrosis seen in different pathologies. So this is diffuse diffuse reactive interstitial species. I said fibrosis. Okay, fibrosis, infiltrative and focal, and we can see the equivalent pre and post values here. So it is not too high here. You can see here it is so diffuse in the infiltrative interstitial fibrosis, and we see 1024 milliseconds. And we just need to note here that, the increase in native T1 or native T1 values are subjected to the field of MRI that you use. It is usually lower in 1.5, and then in 3, it is a bit higher, and it is also center specific. Okay, so yeah, so there's also an agreement between LG and ECV in cases of focal abnormalities in myocardial ECV. So this is just almost the same explanation like we did the other time. You can see the ECV values correlating with what we see in the LG in chronic MI, in acute MI, and in hypertrophic cardiomyopathy in myocarditis cases. Okay. So we see challenges. I'm saying here that there are challenges with in assessing diffuse abnormalities in myocardial ECV with conventional LG. I've mentioned it before, and that is the reason why we keep using the T1 and ECV to also check some. Okay, so T1 to check diffuse fibrosis, ECV to also correlate it, and then to check for ongoing inflammation, as you can see that you can see in the myocardium. So what are the factors affecting myocardial fibrosis imaging? Signal to noise ratio. At times you realize that what is it called? The myocardium is not completely nulled. So in such a case, you see that the image is not optimal enough to be post-processed. Okay, type of sequence used and contrast to noise ratio. Okay, so this I will not really go into it. It's just a guideline for LGE cardiac MRI. What is saying in brief is that you need to identify and standardize the pulse sequence that you want to use, and then you need to look out for what is it called? You need to look out for imaging parameters such as thickness and the gap and the in-plane image resolution. Okay, same here. When you are post-processing, you need to report it very well. When you see any pattern, you need to report it. You identify the mass of enhancement, and then you calculate the mass relative to the total to total myocardial mass, which is the percentage. This ones come automatically with some software that we use in post-processing. Okay, so this application, I will just quickly brief it because of the time. So what we did in the lab is to check the phenotypes of inflammation, fibrosis, and remodeling in our lab, and we use cardiovascular, magnetic resonance, and autophagy markers, and we recruited 47 patients, scanned them, and then we also correlate the result with some markers, RHD being rheumatic heart disease being of inflammatory etiology. Okay, so this is just what we use in characterizing them, like RHD confirmed on echocardiography, and people who are contraindicated for a CMR, they are not allowed to be scanned. Okay, so this is me post-processing, and then we are putting them in the scanner there. Okay, and then what we found is that we matched them, so there was no what is it called? There was no significance in the matching, which means the matching was okay. Okay, so what we found is a reduced ejection fraction compared to the control, significance on the left and the right hand side. And then we also look at the native T1 and the ECV values. We realize that in our patient cohort, we have about 1,280 mean native T1 value pre-contrast, and then ECV, we have about 38 of them in the 38% across our cohort. Okay, so we also use CMR to stratify our valve, to look at the frequency of valve involvement in that place. But we appreciate it here by looking at the different patterns that we found. On the left-hand side, we see the valvular involvement, subtle valvular enhancement, and on the right pattern, you see the control here, and then you see patchy distribution. On the palette on the C here, you see what we are talking about the other time. This is mid-wall enhancement, and we also found it around the inferior, mid-inferior lateral portion of the myocardium. And this D part, we have the diffuse. So of note is that in our patient cohort, about 36% of them add diffuse enhancement followed by patchy enhancement. Okay, so this is the scene, an example of what we found. We see the valvular mitral stenosis here on the other palette. We see you can see the jet here in the coronal view of the LVOT. You can see some moderate regurgitation here, and then you can also see some aortic regurgitation up there. So I just put some static image there, and then let me just run through it, and this is what we have. So okay, so I think we are there by our audience poll. Now the first question, if you are really following me, is that what the types of myocardial fibrosis include: A, infiltrative interstitial; B, replacement; C, adventitial; D, endomyocardial; E, reactive interstitial. So the question is, the type of myocardial fibrosis include all of these except which one? So we can put the answers in the poll. I cannot see it here. Can I?
Yes. So please write it in the chat. I hope people can.
Okay. Okay. You want me to copy it and write it in the chat? No. Can you? Oh, no, not me, right?
The participants should write their answer in the chat.
Oh, they're writing it there. Okay. So it's what we talked. It's what we talked about. So let me know the percentage. Let me know what people are saying there, if they are really following me. Infiltrative. Okay.
So far nobody has written. Oh, someone says D. So
D.
endocardial?
No, I mean, except, so all of them, we have about 4 of them that I mentioned, and then except one of them. So somebody said D. Are you sure it is D, endomyocardial? Did you hear me talk about the error? Yeah, somebody said replacement. Are you telling me the types, or you are telling me the one that is wrong? Let me repose the question. Bring out the one that is wrong in the listed options. Bring out the one that is wrong. Okay. So I think I mentioned infiltrative interstitial. I mentioned reactive interstitial. I mentioned replacement, which is the scarring fibrosis. I also mentioned endomyocardial fibrosis. What I did not mention is adventitial fibrosis. That is the wrong answer there. Yes, thank you, Norbert. You just got a question now. All right, so let's quickly go to the second one. Okay, good. This one is here now. I want to know if you really followed me. Pattern of enhancement on LGCMR myocarditis is A, subendocardia, B, patchy, C, diffuse subepicardia, transmural more often in the inferolateral wall, but also other regions with a more diffuse distribution. D, diffuse subendocardia. E, characteristic midwall or subepicardia. So what is your answer? Which one will you spend money on? I'm waiting. Think about it. It is what we talked about. We saw patchy, subendocardia. Should I give you a clue? Yeah. Okay. It is one of the diffuse subepicardia. Oh my word! Did I give it away? Did I give it away just now? Oh, all right. Okay,
Yes.
so it is yes, yes. Thank you, Georgie. Thank you, Titi Nokwe, thank you. So it is diffuse subepicardial transmural. I said it is more of diffuse, and it is found in the inferior lateral wall. And I actually put it into context when I show some of the work we did in our lab. Okay, another one. Yeah, this is just a yes or no answer. Do we still need myocardial delayed enhancement for a comprehensive tissue characterization in the area of T1 mapping? Yes or no? Yes or no? A or B? B, okay. Which is yes. Oh, yeah. Yes, we do. We do. Because LG is also very important. It helps in diagnosing myocardial infarction and, yeah, focal fibrosis. T1 mapping can quantify. Okay, let's go to the last one. This is the last one. Tricky. Factors affecting myocardial fibrosis imaging include all these except. So pick out the wrong one, the wrong answer. So 1, signal to noise ratio. B, access to MRI. C, contrast to noise ratio. D, oh, sorry about that. I think I missed the typing. ABB, oh, should I give that away now? I don't think so. Okay, so yes, except. People are paying attention. I love this. Okay, so thank you so much. The answer is B. So yeah, factors affecting MF imaging include signal to noise ratio, contrast to noise ratio, and the type of sequence used. Okay, I think that is it from my side. Okay, and then this is just a summary of what we talked about: myocardial fibrosis, types of it, imaging modalities, CMR applications, and then parametric mapping. And here we are. I have asked my question. Do you want to ask your question now?
Yes, so if someone has a question, please write it in the chat, or maybe you can raise your hand and I can unmute you.
Yeah. Oh, thank you. I'm sorry I did not leave my email address. That's another thing that could have saved us much time in case we want to follow up on the talk. Okay. Yeah. I don't think there is question.
Not, doesn't look like it, no.
Okay.
Well, if you want, you can leave me with your email address and I can provide it to them, or we can write it in the chat now.
Okay, let me quickly write it in the chat.
Yeah.
Oh, thank you so much. I appreciate it too. Solomon Peace 23@gmail.com. That is, yeah, that is my email address. Thank you, Naomi. Merci beaucoup. Thank you. Merci. Thank you so much.
Okay.
Thank you.
Seems that there's no more questions. But yeah, thank you very much from our side as well. It was a very informative session.
Thank you.
Yeah.
Thank you.
I'll stop recording now.